Everybody, welcome to the Very Connected podcast. And tonight we have a very special topic. Even though we're a vitamin company, we're sponsored by ProCare Health, we've really not talked about vitamins all that much. And tonight we're going to be really focused on that. So our topic is all about vitamins post-bariatric surgery. We're actually even going to go into the pre-op phases. And we're being joined by our newest ProCare Health team member, Heather Mackie, who's a registered dietitian and just incredible human. She's been in the industry for about 20 years. We went to a conference last week. Heather joined us and she was voted as an industry partner through the Trio Foundation. And I don't know, Heather, I don't feel like I can do you justice. Like, chime in, say hello. And for all of you joining out there, say hello in the chat as well.
Thank you, Brenda. Hi, everyone. You're so sweet, Brenda. Really building my ego up here. I like it. Can I stay on longer? But yes, I'm a bariatric dietitian. Come from working in a bariatric surgeon's office, and I've worked for a couple different supplement companies, and really just enjoy I call it the puzzle of helping patients find supplementation that will work with them, because bariatric surgery is an amazing thing to help people, go into remission as far as some of their comorbid conditions like diabetes, sleep apnea, and many other conditions that patients struggle with. But I've personally seen, when I was practicing, patients then end up with night blindness or even the inability to walk, like literally rolling into the office in a wheelchair with this new onset short-term paralysis from simple vitamin deficiencies. And so it immediately sparked this passion of, let's help these patients get healthier, but let's not trade one comorbid condition for something else that can be prevented from supplementation. And so I've just loved coming back to the land of supplements, that I like to call it, and being able to be a part of ProCare and join you, Brenda. I mean, you don't give yourself enough credit. So you are an amazing human also. And I know everyone I meet is always like, oh my gosh, you're with Brenda. And so this is a lot of fun, and I'm excited to be here. So thank you.
Yes. And guys, if you are wanting to know anything about vitamins, you are in the right presentation, because I am not lying. I have never met anybody as knowledgeable about vitamins as Heather. And I'm not just saying that. Like, if you would see the amount of research that she has done, she had whenever she was showing me some of her stuff, she has spreadsheet after spreadsheet after spreadsheet, comparatives of our vitamins with other vitamins, with the ASMBS guidelines, which we'll be talking about more about. I mean, and knowing what goes together, what doesn't go together. There was things that I've learned, and I've been in the industry for about, I guess it's going on 11, 12 years. And like, literally, Heather, you blew me out of the water with some of the ideals and stuff. So, I say we jump in, we'll get started. I also want to just say, kind of for starters, if anybody is joining us from a facility and they would like their information shared with that facility as being registered and attending, I do that with a great number, probably about 50 different facilities share attendance. And so when you register, if you put the group name, the attendance for the facilities that I share with will be getting attendance next week. I usually wait a week to capture replays, so just be aware. Some patients require, so many attendances before surgery because of pre-op requirements from either their facility or for insurance. So I want to just say that. So next week, I'm also going to type my email in the chat box. If you're listening to the replay, it's my last name, HOEHN, my first initial B at ProCareNow.com. So my last name, Hain, HOEHNB at ProCareNow.com. So that's my email in case you do have questions about any of that. So I say we get started, Heather.
Awesome. Well, let's get some fun slides up here real quick. All right. Listen, so I'll let you get us going. Brenda?
Okay. Awesome. So we kind of already talked about what we're going to be talking about. So we'll go ahead and just move on along to the next slide. The big thing, guys, we're going to be kind of diving into is pre and post-op issues with vitamins, why you would want to take them, how you take them, what a normal patient's regimen might look like, whether whatever surgery breakout you are, whether you're a lap band, a sleeve gastrectomy, or a gastric bypass patient, a duodenal switch, a SATI. We're going to be talking about a lot of different varieties. We're going to be talking about how to get past deficiencies. I'm sorry, how to get past if you're having problems with vitamins, we're going to be talking about that. I also want to just say, if you have questions, guys, please feel free to type in the chat box if you're on the live event, or type in the Q&A. Okay. And so preoperative deficiencies, we're going to kind of start there. I thought I had typed the return button on my email. Sorry about that, guys. I'm putting it in now. So about 80 to 100% of patients experience a nutrient deficiency prior to surgery. Let that sink in, okay? So most common are vitamin A, D, C, B1, B12, iron, selenium, zinc, and folate. And what I want to say is most programs normally will do pre-op labs before surgery. I know with the program that I worked for, it was a inpatient, or it was a program through a hospital system. We took them with the pre-op labs right before surgery, so we didn't have a lot of leeway as far as time-wise to start treating. Some programs do check them further out than that. I know, Heather, you said that was a big thing for your program. You were checking to try to get those deficiencies treated before surgery.
Yeah. We definitely checked them pre-op, and then if something was low, and depending upon what it was, we might try to correct it and then check it again prior to surgery. But it just kind of depended on the situation and which nutrient and how severe the deficiency was.
So, and I know there's questions coming in. We're going to try to answer some of those in between. So please keep them coming, guys. Additionally, obesity is a singular risk factor to nutrient deficiency. So even though your weight may be heavier, it doesn't necessarily mean that you are still absorbing a lot of nutrients. Adipose tissue utilizes vitamin D differently in those with extra weight versus a normal weight. And some of the other vitamins can go along that same line as well. And treating pre-op deficiencies optimizes nutritional status. So kind of like Heather said, if you're kind of getting a head start on things, it can help decrease your healing time post bariatric surgery. It can also help decrease your risk of increased nutritional deficiencies post-op, and it makes that transition easier. For me, I was not a big medicine taker before surgery. I was on one medicine, which was a blood pressure medicine, and taking the vitamins was definitely a new part of the routine for me. And you can go ahead, Heather, if you'd like. So post-op deficiency. So even though food is medicine and has a functional value, anytime someone eats less than 1,500 calories a day, they can be at risk for nutritional deficiencies. And after surgery, obviously, you're not going to be taking in even probably 1,500 calories, especially initially right after. And also some food avoided. So that can increase your risk as well. So if you're avoiding some foods, maybe because you can't tolerate them yet, or they're not quite on your diet as you migrate into maintenance phase, it can be some issues there. So concern is this can actually lead to some issues. Some of them are minor, but some of them can be more major and even lead to permanent problems or even death. And that's scary to think about. And this is not to scare anybody at all, guys. This is just to kind of make you aware that how important it can be to take vitamins. Okay, Heather.
All right. So we're going to spend some time talking about the ASMBS guidelines. So you're like, well, what is that acronym? That's a lot of letters. So it's the American Society for Metabolic and Bariatric Surgery. So just like you have the American Medical Association, that's the governing body for the Medical Society and physicians. This is our governing body for metabolic and bariatric surgery in the treatment of obesity. And our guideline paper, our white paper, scientific paper, was actually a combined paper through the American, and I'm going to butcher all of these acronyms, but I think the American Academy of Clinical Endocrinologists, the Obesity Society, the ASMBS, the Obesity Medical Association, and the American Society of Anesthesiologists. Oh my gosh, I got through all that. So let's break this down. First, everyone take a deep breath, okay? We are going to try to make this as simple as possible. It looks confusing, and I can tell you, Brenda and I played with this chart like 50 times to try to make it look less confusing, and it's confusing. It's very overwhelming, and this is part of why it's so critical to make sure that you have a bariatric program that you're following up with long-term, because that's part of their job, is to know these guidelines and to guide you in the right direction, okay? It's not necessarily your job as a patient to have all of these guidelines memorized or anything of that nature, but we do want to kind of just give you some general high-level information about what you should be looking for. So at the top, we have the 4 main surgery types that existed at the time of this guidelines paper. So I know SADI is a really common procedure now, or it's growing in popularity. But at the time of this paper being written, that was not an approved procedure. So for most practices, they tend to treat their SADI patients kind of like a biliopancreatic diversion duodenal switch. So for the most part, they fall in there. But we have our gastric bypass, our sleeve gastrectomy, and adjustable gastric band. So in general, all patients need a multivitamin. It's usually going to be 1 to 2 per day, and that depends on the formulation. Chewable form initially, and an adult multivitamin with minerals, so not a kid's formula, and it needs to contain iron, folic acid, and thiamine. So if you guys don't have your multivitamin handy, you can, we'll have handouts for you with this information so you can compare this to your label later. But for vitamin D, you'll want at least, and they changed the, how, like the, what's the word I'm looking for? The unit of measure for vitamin D. So you should find somewhere in the range of 50 to 75 micrograms per day. But this may also be combined with your calcium product. So you might have, for example, 25 in your multi and 25 coming from your calcium to make the 50. But the ultimate goal here is your lab level. This is called 25 hydroxy D. It's your vitamin D level. And we want that to be greater than 30 nanograms per milliliter. So higher than 30 is the goal. Vitamin E, about 15 milligrams in the multi. Everyone needs at least 12 milligrams of thiamine in their multi. And folate, about 400 to 800 micrograms. But again, we changed the unit of measure because we like to complicate things. And so about 667 to 1333 micrograms of what's called dietary folate equivalents in your multi. If you're a female of childbearing age, you will want to have a little bit higher folate, and that's just in case you were to get pregnant to prevent birth defects like neural tube defect or spina bifida. So B12, there's a couple different ways that you can take B12. At the end of the day, you just need enough to have normal lab levels. But if you're taking it orally, like what's in your multivitamin, what's on your label should be somewhere in the range of 350 to 1,000 micrograms per day. If you're doing a nasal spray, it will be whatever the manufacturer recommends, and an injection is about 1,000 micrograms per month. When we get down to vitamin A, it starts changing by surgery type. So band is lower at 1,500 to 3,000 micrograms. And sleeve and bypass are the same, 1,500 to 6,000 micrograms. And our switch friends are the highest because it's the most aggressive procedure, and they need about 3,000 to 6,000. Vitamin K is 90 to 120 per day for everyone except for our switch. and they need additional totaling 300 per day. So iron, our low-risk patients need 18 milligrams of iron in their multi, and you should not take this at the same time as calcium, which we'll cover here shortly. Our sleeve, bypass, and switch patients, or any menstruating female, or those with a history of anemia, will need more iron at about 45 to 60 milligrams total. So again, part of that could be in your multi, and part of it might be in a separate iron, but just at the end of the day, you need 45 to 60. Zinc for our band and sleeve friends, about 8 to 11 milligrams in the multi. Our bypass, 8 to 22, and our switch friends, 16 to 22. And then copper, about 1 for band and sleeve, and then 2 for bypass and switch. And there's a couple notations down here, but we'll kind of look at those in a little bit further. And again, take a deep breath, because I'm going to tell you guys the great thing about this. Most of your bariatric formulas, and I say most because you still want to look at the label and compare, contain what's in this chart. Most of them. So if you get your multivitamin and you have a good high quality bariatric multivitamin, the only thing you're going to need is your multi and then a separate calcium. So when we look at the calcium recommendations, this one's way easier. So for our band, sleeve, and bypass, 1,200 to 1,500 milligrams daily. And because the switch is more aggressive, more intestine is taken, they need a little bit more, 1,800 to 2,400 total. The difference here is this is all sources. So what that means is food and supplements. So it can be a combination of the two. Citrate is the preferred form if you're doing it from a supplement, and it needs to be in divided doses. So what that means is this point number 2 here. There's a max absorption. So you can only absorb about 500 to 600 milligrams of calcium every 2 to 4 hours. So if we just, for easy math, say you need 1,500 milligrams of calcium a day, it doesn't matter if there's 1,000 milligram calcium product out there, you're still only absorbing 500. So you want to maximize your dollars and maximize your health benefits too. And then do you not, oh yeah, go ahead.
Oh, no, I'm sorry. I didn't mean to interrupt you. I was gonna just tell everybody too, guys, if you're like kind of like panicking, thinking, oh my gosh, how am I gonna remember all this? We actually have handouts on this on our ProCare website, which I will show you where those are. Towards the end of it's under procarenow.com, very connected tab, and we will definitely do that. And we have them divided out for all surgery types, and then also a handout that includes all of them. So you do not have to remember any of this. Like if you're wanting to come back and compare, it is all under procarenow.com, very connected, and our support group handouts page. So just to kind of wanted to let know, and Heather too, finish up with whatever you're doing there too, but there is some questions coming in, and I was going to see if we could answer a few when you get a break.
Yeah, I was starting on the first one, so and then started, but yeah, so I started on one. And then the last point with calcium, don't take it at the same time as iron or a multi that contains iron. And the reason why is you'll actually block your iron absorption, so you're just putting yourself at risk for an iron deficiency. So when we talk a little bit about specific recommendations, while we have our guidelines, your healthcare provider, your program might not match those guidelines. And that's normal. That's not an uncommon thing. You want to follow the instructions from your healthcare team, not what ProCare is saying in this webinar, not your friend or family member, not Dr. Google, as much as I love to Google all my symptoms, not your online bariatric buddies, and not a social media influencer. Please, please, please follow the instructions of your healthcare provider. They may adjust and modify from those ASMBS guidelines. And I've even seen certain practices where there's multiple surgeons and not even the same, each surgeon has the same recommendations within the practice. So again, just make sure you're following the instructions from your surgeon, your dietitian, your healthcare team. because what they're doing is they're individualizing the recommendation to you. So this is just you looking in the mirror. The guidelines are just that. They're a place to get started. They are not the end all be all. It's not, you're going to follow this to a T. So while we have all this in a handout, don't stress. Again, this is why you have a healthcare team. This is why you need to see a physician. This is why we get blood work done. And they're going to develop a plan for you. They probably start with the ASMBS guidelines, and then it kind of filters down. And they're going to take it from there, marry in their program's recommendations, their individual surgeon's recommendations, your medical history, your lab results, any medications you're on, because certain medications can increase your risk of certain deficiencies, but then also your preferences and beliefs. And this allows them to customize a supplement plan that's just for you. So I'll stop there.
So Heather, is it okay if I take just a moment and kind of do a couple questions? Because there is someone's coming in. There was one in the chat feature, which I'm going to go back here for just a little bit. And it's actually, it's a question that said, I have bypassed 9 weeks ago and the color of my poop is light tan, cream color. Is that normal or a sign of some sort of deficiency? I am very good at taking my vitamins every day.
So that's actually the one I was starting to type out. So definitely, like I say, with anything, check with your healthcare team. Obviously, this podcast, this live is not about medical advice, but in general, being that you had gastric bypass, this is likely due to the slight malabsorption that patients experience from that procedure, and that can cause that lighter color in your bowel movements. So likely is not any sort of deficiency. It should normalize out over time. Remember, you're still early out post-op. You're not eating a ton of food more than likely, which is to be expected at that stage. So it's very common to have changes in your poop, for lack of a better word. We get to talk about poop when you're a dietitian. It's fun. And so that is something that certainly you'll want to mention to your healthcare team at your next follow-up, but more than likely just related to the changes in your gut.
And also we have a question, for how many weeks or months post-op should vitamins and supplements be chewable? When can I start taking capsules, tablets or capsules? And I know this is going to be one of those questions we're going to be answering again, but go ahead, Heather.
Yeah, this is a great question. So I have my personal opinion, and I'm sure Brenda has hers too. But at the end of the day, ultimately, the answer will be, what does your bariatric surgeon say? I will tell you that when I first started practicing as a dietitian almost 20 years ago, the recommendation was you did chewables for the first year post-op. And I have seen that lessen. There's even some programs now that allow their patients to immediately start on capsules or a swallowable tablet, as long as it will break down in the bariatric gut and it's not too large. And it depends on the patient too. It depends on what they're able to tolerate and how they're doing. But again, every surgeon has slightly different recommendations. So please follow the instructions from your surgeon. But we have seen that lessen just because we know typically the sooner we get patients to capsules or those swallowable tablets, the more we see adherence go up, which is the name of the game. So if you're struggling to get in a product and you're not quite approved to move to chewables, have that conversation with your physician. See if they're okay with it, because sometimes they will make adjustments. So again, everything in medicine is risk versus benefit.
Oh, this is a great question, Heather. We knew it would come up. Heather actually had messaged some of her dietitian friends about this one, because the guidelines are a little generalized on this. How much iron is recommended for men post-bariatric? He has bypass surgery, but we'll talk about everyone.
Yeah.
All of them.
So this one, Brenda and I talked about this because it says, if you read it, and you can sit there and read it a couple different ways. You can read it as low risk patients and male, which would be just males, need 18 milligrams. But then anyone who's had a sleeve, a bypass, or a switch needs that higher amount of iron. So I can see it both ways. And the consensus in the industry, from what I can tell, from most of the dietitians and physicians out there practicing, and even some of them that are working on authoring the next version of this paper, is that for the majority of programs, when we're talking about sleeve, bypass, they tend to do somewhere in that range of 30 to 45 milligrams per day of iron for men. For women, if they're childbearing age, you're probably going to see that 45 is probably the recommendation. And if they're either postmenopausal or for whatever, not menstruating, then probably in that 30 to 45 range. When we're talking about band patients, most patients are fine with 18. If they're a female that has had a history of anemia, or something of that nature, they might go up to 30, but for majority of band patients, 18 tends to be the recommendation. And then for our switch patients, while the recommendations do say 45 is enough, most programs are finding that actually is probably not, and it's closer to the 60 recommendation. So most of the programs I'm talking to are recommending that their switch patients, regardless male, female, start on about 60 milligrams of iron. But again, talk with your physician. They probably got an iron panel on you prior to surgery, or if you're post-op, they've probably gotten one recently, and they can adjust your recommendation. But the other thing I'm going to point out is look at the trends over time. Keep your lab records yourself. And don't just look at, is it normal, is it low, is it high? If it was 50 one time and it's 40 and both are normal, don't just say, okay, that's fine. Say, okay, that's trending down. What have I done different? Am I not taking them as much, or do I need to look at increasing it? But certainly include your healthcare provider in that decision.
I'm going to go ahead and take these two and then we'll kind of go forward. But if anybody else has questions, keep them coming and we will answer them at some point if we're able to. Next question. I've had bypass 11 months ago. How many ounces should I be eating at a meal? I can eat like 6 to 7 ounces. It feels like more than most. Is it?
And how many months ago did she say?
11.
11
It's
months
almost
ago?
a year.
So this one is very individualized and depends on a couple different things. The surgical technique of the surgeon. I was in one presentation one time, and because gastric bypass and really a lot of the procedures are so different by each surgeon, there's over 200,000 actually different surgical techniques of gastric bypass. So we could both have gastric bypass and have completely different limb lengths, size of our pouch, everything. And so it's really hard to compare yourself to others when we're talking about volume of food or how much of a certain vitamin you need or things like that. And so that's why we see so many differences. But I have had patients that have progressed a little bit slower than others. And so while I would say that's probably a little bit less than some people, it also depends on the types of foods. If you're eating more solid foods than others, then that certainly would be the reason versus if you're eating like yogurt or something that's softer, you likely can eat a little bit more. But I would just certainly touch base with your bariatric program and, talk with them about the food choices that you're having as well as the volume and see if they feel that that's on par with their recommendations. So, but I've certainly had patients at that volume at that stage.
It does not seem like too much, but
No. It is scary though. I totally get it. It's like, you're like, I'm not supposed to eat a lot, and it really is about, and this is the hard part, it's about relearning that sense of hunger and fullness, because those feelings for a lot of patients have gone away. And so we have to start over at ground zero and completely relearn those feelings. And that's hard. That can be hard.
And this other question, 14 years post Roux-en-Y. My PTH is abnormal and calcium is low, but vitamin D is okay. Started Prolia, I hope I'm pronouncing that right, Prolia 2 years ago for osteoporosis. Does this med cause this? Do you know, Heather?
I don't know. I was going to Google. Let me Google it. I'm not sure what Prolia is. As she's saying, it's for osteoporosis. I don't know that it would cause that. My guess is if your PTH is abnormal, I'm guessing it's elevated, even though the person doesn't state. And so you can have elevated PTH and have a normal vitamin D. And what that means is that your body is actively pulling calcium from your bones. Your body will do whatever it takes to try to normalize your calcium level. And your calcium is a funny lab. You have to correct it for your albumin levels too. So I can't say whether or not that's truly low. Oh, she says, yes, it is elevated. So if it's elevated, Lee, that means that your body is actively pulling calcium from your bones. So it is good that they started you on that medication would be my thought process. So certainly important to stay on top of monitoring that vitamin D level and trying to get in the calcium that they recommend, and trying to get that PTH to come back down to normal. But it is a process. It takes time, but you're doing the right thing.
One other thing too with osteoporosis, and I'm not sure if Lee is doing this or not, one thing, strength training or doing some kind of impact walking or like something may also benefit that. So
Yeah. And she said
okay.
levels were normal before the medication. I can't say for sure, Lee, obviously, because I don't know your full medical history, and that's good that you're doing all of those. But my guess would be that that's just a coincidence that it likely was already starting to actively pull some of the calcium from the bones. Because there's a couple other markers that we can look at as well, besides just the PTH, calcium, and vitamin D. But again, I don't have the full picture to be able to answer that. But I don't think that that medication would cause that because its whole job is to try to correct that whole situation.
Okay. Well, we're going to kind of keep moving up, doing all those, Lee says. Okay. So next we're going to talk about feedback loop, and we're going to talk about follow-up. And Heather, you can go ahead and go on to the next slide if you like. So this is kind of a big chart. If you want to take, if you have your phone, you want to take a screenshot of this, that may be helpful because this is not on our handouts, but it may be beneficial. You know, a lot of these, well, bariatric programs decide what labs they want to do in follow-up, but it may be helpful if you're following up with your primary care doctor, or if you just want to double check to make sure that you're getting all that's recommended. It's a long list. Depending on which surgery you have, the follow-up protocols might be just a little different, you know, between the band, the sleeve, the bypass, and the BPD or DS. Overall, it's a panel of lab work and a few additional tests. So we'll just kind of go through it just very briefly. CMP, which is a comprehensive metabolic profile, which checks your electrolytes, your blood sugar, your kidney function, your liver function. A CBC, which is a complete blood counts, checks to make sure you're not anemic, your white blood cell count. Lipid panel, that's your cholesterol levels, that type of thing. Make sure that that's all in check. Bone density, which is a DXA scan or DEXA scan. I actually recently just checked into that because Heather and I, after we did this presentation, I didn't even realize that that was recommended. And unfortunately, my insurance will not cover it until I'm 65. So I got 10 years before I'm hit that marker. And so I'm like, well, I'm not going to pay for it out of pocket. So I guess I'll wait. Haven't had any problems, but it is recommended. 24-hour urine excretion at 6 months and annually, and that is for only the BPD. B12, that is for all procedures, folic acid for bypass and BPD, vitamin A. With the BPD procedure, it's going to be a little bit more important to check those fat-soluble vitamins. Like D is always checked, but A, D, K. Copper, zinc, selenium evaluation with specific findings. So with those are trace minerals. Usually those are ordered separately. A thiamine ordered separately for all procedures. And then your hemoglobin A1C, which checks your blood sugar, not just like a blood sugar check, which can be found on your CMP, that first test, but it actually checks your blood sugar over a period of time. So it kind of lets you know if it stays elevated for a period, like if it stays elevated regardless of what you eat, that type of thing, then you know you might be pre-diabetic versus healthy or diabetic, you know. And then a TSH checks your thyroid. And Heather, you can go to the next screen if you'd like.
So when we talk about the benefit versus risk, as I mentioned before, everything in healthcare is pros versus cons, right? And we have to look at each person as an individual. So we're going to kind of break this down for you guys. And we picked what we have lovingly called the Frightful Five. And so what we feel are the top 5 nutrient deficiencies that we see, the most common, but also the ones that tend to have the most possible risk of permanent damage or detrimental effects. So it doesn't have to be permanent though. So I want to make sure I caveat that. So starting with calcium, we talked about just a moment ago a little bit with Lee. We often see a calcium deficiency reported as early as 9 months post-op. And this can actually cause muscle cramps, muscle twitching, anxiety, irritability, kind of that pins and needles feeling. I've even had pre-op patients that have shown up with calcium deficiency, and we kind of get these levels corrected, and it's a whole lot easier for them to start physical activity. And so that's one of the benefits of, again, checking these levels before surgery. But if this continues on, it can lead to metabolic bone disease, which is a precursor for osteopenia. And that can even worsen to osteoporosis, which is that breakdown of the bone and the curvature of the spine. We tend to think of that as a disease of older women, like 80, 90-year-old women. But because of bariatric surgery and everything we've learned over the years, unfortunately, we've actually seen osteoporosis in like 30-year-old men. And that's just, again, one of those trade-offs we don't want to see. So serum calcium, the lab level, is not a good marker. So when you get that in your lab panel, and regardless of what it says, that doesn't really tell you what's going on with your bone health. We really have to look at PTH, which Lee was mentioning, and we've kind of already chatted about. So PTH is really the big one that's going to tell you what your bone is doing. So if that's elevated, your body is actively pulling calcium from your bone, because your body's going to do whatever it can to keep that calcium level normal. And that's either pull calcium from the bone, or it's going to excrete less in the urine. And so that's why we had that 24-hour urinary in the labs. The other big one that we see besides bone loss, we hear this a lot with our patients, is all of a sudden they're showing up at the dentist office with tooth loss or more tooth decay, more dental caries, things of that nature. And that can be calcium, but also vitamin C. So those are 2 nutrients that we just want to kind of keep in mind. And because vitamin D and calcium are like BFFs, they're like peanut butter and jelly, they go together. So I'm going to cover this one too. About 80% of patients experience vitamin D deficiency prior to surgery, and up to 100% of patients experience it after surgery. And half of patients have a vitamin D deficiency, even though they're taking a multivitamin. So what does that tell us? That the vitamin D and whatever multivitamins patients are taking may not be enough. And that is exactly what we're seeing. So that recommendation of 2,000 to 3,000 IUs or 50 to 75 micrograms, I can tell you there's a ton of patients out there that are still taking additional vitamin D on top of that. So that is very normal. It is not uncommon. There's not something wrong with you. Your body's not functioning incorrectly. It's just we sit in these great indoor settings all day. We wear sunscreen. We're not out very much. The body absorbs vitamin D differently. And when we don't have normal vitamin D levels, it's difficult for our body to utilize that calcium. This is another one that plays a role in muscle pain and leg soreness. So again, a good one to correct if you're starting to do physical activity. It can also compromise your immune system. And I kind of already talked about PTH, so I'm going to skip that part because we've already mentioned that one.
Okay. So risk of deficiencies, we're now talking about iron. So this is one of the 5. Heather had the first 2 here. And iron is common. About 25 to 50% of patients develop an iron deficiency within the first 6 to 9 months post-op. So it's pretty early on. The thing is if you if you don't kind of get a head start on it, I mean, you may even see it even 3 to 4 years out too. So some programs will recommend, vitamins for the first year, and then you may see people kind of fall off the bandwagon with as far as vitamins. So just know it is recommended lifelong because some of these deficiencies don't show up right away. Some symptoms might include fatigue, confusion. All of these things are kind of related to your body's ability, your blood. With the iron, it carries, your oxygen level. It carries the ability to keep you oxygenated and healthy. So fatigue, confusion, compromised immune system, dizziness, headaches, pale skin, brittle nails, dry hair, inflamed tongue or mouth lesions. And if you feel like you are short of breath, like I said, that breathing issue, that might be a sign. Or also, so I already talked about this. Iron carries oxygen to be carried by red blood cells, including muscles, heart, lung. Your blood goes everywhere in your body. So if you're not getting appropriate circulation because of the deficiency, you're going to have symptoms based on that. There's also a symptom called pica, P-I-C-A, which is eating or chewing ice, and the crunchy ice, like Sonic ice. And so if you notice that you're doing that, that might be a sign that you are iron deficient. And some nutrient rules: a deficiency in vitamin A can worsen iron deficiency. Also, if taking high dose iron, take with food to increase zinc absorption and toleration of iron. So with food, high doses of calcium will block iron absorption if taken at the same time. And that's why it's recommended a lot of times that you separate your calcium by 2 hours. And then adequate copper levels are necessary for iron absorption. So lots of little pointers there. And Heather, I'm going to see if there was I noticed there's some comments, but I'm going to look real quick and see if it's anything right now related.
I was getting them. Yep.
Okay. It looks like Heather may have answered one of them. So
I got a couple in there.
is there anything you wanted to say to that, Heather, before I read this next slide?
No, go for it.
Okay. So here we're on B1, thiamine. So especially with this is probably one of the biggest things I want to note. It can occur within 18 days post-op. So it can occur very, very early on, probably earlier than most other vitamin deficiencies. And I know we had a patient that came into the hospital very early, and I know Heather's recognized and has mentioned the same thing. The patient that I remember that came in early on, it was kind of a mystery in the beginning. They didn't initially think vitamin deficiency. They were checking her for stroke. They were checking her for neurological issues because it was all those type of symptoms. And as soon as they were able to figure out that it was a B1 deficiency, they got that B1 going for her, and her symptoms stopped fairly quickly. So the reason why so early, it can be because of that change in drastic diet. Also, sometimes patients will have vomiting. Make sure, the reason why we're kind of telling you guys this, be your own advocate. If you're going into the hospital post-op and you've been vomiting or had problems, you could mention that you are concerned if you are having neurological symptoms about your B1 level. Some symptoms: memory loss, confusion, irritability, trying to talk too fast, nervousness, loss of appetite, numbness in hands or feet, like a prickly sensation, so burning sensation. And then also a friend to B1 is magnesium. It's needed for optimal thiamine absorption and neurological function. So this one can be tricky, and again, we don't want to scare you, but it can lead to paralysis if not treated, coma, and even death. So be an advocate for yourself, and be aware that if you are having any symptoms, to make sure and get your levels checked right away.
If you go into the emergency department and you hear them say anything about they're going to hang fluids, a banana bag, anything like that, raise your hand, have a friend, family member, whoever's with you, raise their hand and say, make sure you put thiamine in that. Call my bariatric surgeon. That needs to be 100% shared with them, because that's what happens is the liver only stores about that 18 days worth of thiamine. And thiamine is used to break down carbohydrates. And in those fluids, they put carbohydrates. And so what you're doing is just worsening that. And so it can really exacerbate a thiamine deficiency.
And somebody's asking about these handouts. This particular presentation that we're showing you guys is not shareable, but we do have handouts that summarize these things for you, and they are accessible on our support group handouts page on our ProCare website. I'll post a link about that again too.
Thank you. All right. So for B12, about 30% of patients and maybe up to 75% of gastric bypass develop a B12 deficiency post-op. It is not common, not common. I'm going to repeat that. If you're taking a high quality bariatric multivitamin that's formulated with that high dose B12, somewhere in that range of 350 to 1,000 micrograms per day. The common symptoms are similar to many of the other nutrients we see, unfortunately. The fatigue, the weakness, the depression, numbness and tingling in the hands and legs. The one we see that's a little bit different, and I've personally seen this in the office, I used to have my patients walk down the hall from the front waiting area to where we would weigh them, and then they'd walk across the hall to my office. And literally she was doing like that we called it the drunken sailor walk, but it's literally like a drunk person walking. They can't stand up straight, difficulty maintaining balance. And if there's not another reason, like orthopedic reason for that, then you definitely want to check B12 levels. Constipation, certainly there's a lot of reasons constipation can occur, but this can worsen it. And tongue soreness. So I'm calling these the mortal enemies of B12. You actually only absorb 1% of B12 orally. So when you look at your vitamin label, you're going to see this ridiculously high percentage. Like I think it's like 49% and some 49,000% and some change on the ProCare. And don't quote me on that. I might get fired if I'm wrong. So just overall, it's just a really, really high percentage. Like I even had a phone call with a patient last week. They're like, is this really right? This seems like way too much B12. And the reason why is because you only absorb 1% of what's actually on the label. So if the product has 500 micrograms, you're only absorbing 1% of that 500. And so what we do is we counteract that passive diffusion absorption by putting in a lot of B12. So you're still getting what you need. Some people have an increased risk, so anyone who's a strict vegan, alcoholics, those with a gut bacteria called H. pylori. A lot of bariatric programs test for that prior to surgery. And those on certain medications, which these are a lot of our bariatric patients, metformin, which is commonly used to treat diabetes or insulin resistance, and many acid reducing medications like Pepcid, omeprazole, Zantac, I think is another one. So a lot of those PPIs are H2 receptor agonists. Another thing that puts you at risk, if you're struggling to reach your protein goals, that will actually increase your risk of a B12 deficiency too. So certainly kind of everything in nutrition, unfortunately, plays a role with each other. And so that's why, you know, again, balance and moderation is so critical. So when we talk about, we've kind of talked about the risk. Now we know there's some benefit. Let's talk about how do we overcome the barriers when it comes to being adherent. Like, okay, we want to do this. We want to take our vitamins, but I'm sure you guys could list out in the chat, what are the reasons that you don't take your vitamins? And I would venture to bet that we got the top 7, but I'm curious to see if you guys have one that we didn't get. So we're going to cover a few of these. So starting with taste and texture, try until you can't try anymore. There are a ton of options out there. Find one that you like and sample. I know we have free samples. We'll drop that link in the chat here in a little bit, but continue to try new products. Your taste buds will change from pre-op to post-op. They'll even change as you go throughout the process. You'll get tired of a product. You'll like it and then you'll hate it. And also talk with your physician. Are you allowed to progress to capsules? And then as far as texture, try all of the same suggestions for the taste barriers. But on top of that, Try a few various delivery systems. I'm sorry, someone's knocking at my door, of course. Perfect timing. So if you hear my dog, it's all normal. So hard chewable tablet, soft chews, capsules, even a bariatric safe coated tablet that goes down super smooth. There's now liquids, there's powders that you can mix up into a liquid. I know we even have a chocolate bar. I mean, how can you go wrong with a calcium chocolate bar? I mean, it's pretty darn good. And then the other thing that I'll tell you is different sweeteners will give products different textures. And so because of that, you might want to try different products to allow yourself to tolerate them. Mute myself and tell this person to go. Mute button left, sorry.
Okay. I think Heather's took a little break. I'm going to answer a couple questions here in the Q&A while she's doing that. So there's a question, will a link to this webinar be available later for us? So much good to hear. I'd like to rewatch. Yes. So if you're listening to the live event, it will be available post this until the end of the month. Using the same exact link you used to register for. It's also on our ProCare website, which I'll show you how to get there too as well. It's procarenow.com. We also place all of our videos on YouTube and the Very Connected podcast 1 week following the event. So
thank you. Sorry, we have some really aggressive solicitors lately. So he needs to sell him some vitamins. So anyways, another one, price. Price is a big factor, especially this day and age. Inflation is such a big problem. And we don't want to see people where they're choosing between paying their electric bill and purchasing their vitamins. That is a terrible situation. I hate hearing those stories. And that's one of the things I love about joining ProCare is that affordability is a huge, huge factor here. There's a lot of options out there. You know, again, ethically as a dietitian, I know Brenda's a registered nurse. You know, we always think about the patient first. Yes, we work for ProCare, but at the end of the day, we're, you know, helping improve the lives of patients. And so if it's not ProCare, find something that you can take, find something that's affordable, find something that will work for you, that you can purchase long-term. But I will say, make sure it's high quality, and we'll talk about how to determine if it is. And be mindful of the, I call them add-ons. So sometimes you think you're getting a more affordable product, but then when you look at the label, you need to add X, Y, and Z. So you end up actually spending more money and having to take more products throughout the day. So it doesn't really save you time, money, effort, any of it. So just do your homework. And then a lot of companies offer subscription services and free shipping to save money. And you might even be able to use your health savings account or your flex savings account to purchase your vitamins. Now, this is not something that ProCare determines. This is something you have to discuss with the company that manages that account and or your employer. But a lot of times patients are able to use that. And it's an ongoing purchase that you can plan for. So as you're getting into open enrollment here in a few months, if that's something you're allowed to do, you can account for that for next year and put it into your HSA dollars. So quality, a lot of people say, well, supplements aren't regulated by the FDA, but actually they are. It's just a very loose regulation. So some of the questions you want to kind of look at, is it a certified good manufacturing practice facility? What that means is they're checking all the raw ingredients before they put it into the product to look for contaminants. Then they're also testing a couple of ingredients at the end of the final product to make sure that what is listed on the label is actually in the product. And then where is the product made? We actually take it a step further and do independent third-party testing to check all of the ingredients, not just a couple, not a spot check, because we want to make sure that if you think you're purchasing X, Y, and Z, that you're getting it all. And then you can also see if it's consumer lab approved. So
okay. before we kind of go on to this next one, there's a couple that I'm going to answer. We're going to answer real quickly. There's a question, does it hurt you to take extra vitamins although you're already taking a high quality bariatric vitamin? And do you want to answer it, Heather?
Go for it if you want to, or I can, it doesn't matter.
Yeah, I would say, so you're not like, you have fat soluble and non-fat soluble vitamins. And depending on what you're taking, can make a difference whether or not how you're absorbing those or whether your body's just automatically getting rid of those. So for the most part, most of them you just pee right out, but A, D, E, and K are fat soluble, meaning they kind of hold so you can get too much of those. Anything you wanted to add to that, Heather?
There are upper limits to a few of the water soluble, even though they're technically supposed to be excreted in our urine. It's rare, but there is the risk of toxicity, and so that's one thing with supplementation I'm big on is getting the proper level of supplementation to prevent a deficiency, but not over supplement to cause a toxicity. So it is definitely something to take into consideration. Kind of goes with the old adage: too much of a good thing is not a good thing. So get enough, but not too much. Yeah.
And I'm
Initial
just
berry
looking through this.
vitamin my wife took gave her hives. So I'm guessing on that one, Chris, that I mean, there's a lot of things that could cause that, but some sort of either additive or inactive ingredient or something like that could have caused it. Or sometimes certain products use niacin instead of niacinamide, and that can cause like a flushing, not necessarily hives, but a flushing. But there's a few things that could have caused that. So I hope that she's found something that has worked for her now.
And here's a great one. Are you allowed to drink after the vitamins, or should you be waiting the 30 minutes before and after, like meals?
Oh, that's a great question.
Yeah.
So I have never heard a surgeon say that you can't drink with your vitamin. Um, again, follow the instructions of your healthcare team, but I've never heard that. And in fact, drinking fluids with your vitamins can sometimes help reduce the nausea. So I actually think it's a good thing to drink with your vitamins.
Absolutely. In fact, I was telling Heather, I think it was you. That's one of the things that I noticed helped me more than anything, not just taking with, because taking with food seemed to help a little bit with the iron, but when I started making sure I was getting a lot of fluid with them, that seemed like it made a big difference for me. And I had a visit with my program where they prepped me for surgery. They gave me a goodie bag of samples of each bariatric multivitamin on the market. Not really a question, but I think it's a great thing to remember because, guys, get your free samples, regardless of where you get them from. A lot of programs, some programs will charge you a little bit for samples, but some, I know ProCare, their samples are free. Try different ones, see what you like, because that is very important. And one more I'm going to just take before we kind of move on. For calcium supplements, is it best to divide the dose into 3 times a day, or are there 1-a-day calcium supplements? Heather, you want to get that one?
Yeah, so unfortunately, I wish I could make everyone's life easier, but no. You can only absorb about 500 to 600 milligrams of calcium at a time. That's just how our bodies are designed. It has nothing to do with what type of calcium or the brand or anything like that. It's just science. It's just how we work from a biochemistry standpoint. And so, unfortunately, yes, we do have to divide the doses, and it's a pain, and I know, and it's not fun. But some people, what they do is combine their food and their supplements, and that's one of the things you'll see in the handout. Is that for some people they can get away with just 2 times a day of a supplement, and then including dairy foods as well as part of their intake. But for some, they do need 3 supplements a day. It just depends. And then there's a patch question. I'll answer that in the chat while if you
Okay.
want to do the next slide.
Okay. So how about number of doses per day and ease of taking? Those are, when it comes to like sticking to your vitamin, for me, those were probably number one almost. I mean, everything plays into it, but for me, that was a big thing. So Heather just talked about the calcium. You know, you want to space that 2 hours apart from your multivitamin with the iron because those two don't usually go together too well. And so the calcium, you want to space out from that. So usually 500 to 600 milligrams of calcium per dose. and then space throughout the day. So vitamin D needs to be optimized in that situation. And then iron, you have 3 different things to kind of consider with that: vitamin A, copper, and food. So first of all, low vitamin A will worsen iron deficiency. Adequate copper levels are needed in order to get that iron in, and take iron with food to maximize zinc absorption. So those 3 things. Again, guys, this seems like a lot, but if you just take a bariatric multivitamin, you should be covered with these things, and then the calcium separately, okay? Thiamine, magnesium is needed for optimal thiamine function. So you want to make sure you have a good balance of those. Protein, you know, a lot of times people are wanting these high levels of protein, but usually the body can't absorb more than 13 grams per dose of protein, and low protein increases the risk of vitamin B12 deficiency. So these are a lot of things to remember. Maximize, big thing is maximizing combo products, taking a bariatric vitamin. And if you feel like that you need the extra B vitamins, or you want, I mean, everybody's body absorbs differently. And like Heather said, the B vitamins are sometimes not absorbed well orally. So you can also take B complex nutrients along with that. Those do come in like sublingual formula. There's a nasal spray out there. There's also shots that you can get from your provider. And the ease of taking makes a huge difference. You want to make sure you have an easy regimen. Some of these bariatric multivitamins out there in the market, you have to take 3 or 4 times a day, or 3 or 4 tablets, can make it kind of hard. So if you can kind of cut it back to 1 a day, making it easier, unless that's not a problem for you. Some people that may not be a problem, but for me, trying to make my regimen easiest, that was an issue. And then if you do the multivitamin, the calcium separately, and figuring it into your day. For me, I actually set timers on my phone, as silly as it is, because I forget. Anyways,
It's
I'm
not
done
silly.
with that slide,
It's
Heather.
smart. It's not silly. It's smart. So
And
I
then, oh, go ahead. Is this your slide? Go right ahead.
think this one was yours, actually. I can't remember now.
The big thing is most of these we've already talked about. So I'm going to summarize. You can take chewables or liquids to help reduce nausea, depending on which works better for you. You can try taking it with food. If food doesn't seem to be the issue, try it with lots extra water or fluids. Also, sometimes people will take them at bedtime to help sleep through that period where maybe the vitamin is making you nauseated. Some of the culprits for nausea may be the iron in it. If it's iron, you can try an iron-free formula and then take the iron separately. Iron that's ferrous fumarate, chelated iron, or carbonyl generally is better tolerated. I know our ProCare vitamins are made with fumarate. So in hopes that those don't hurt the stomach as much. So kind of see what is in your vitamin. If you are nauseated, talk with your provider, try different types or forms. Also, zinc citrate tends to be better tolerated than zinc oxide. Calcium citrate or true cal tends to be better, it's well tolerated, maybe tolerated better than carbonate. Carbonate can cause an upset stomach and is generally recommended to take with food. And constipation is always a big thing, not only just with vitamins, but in general after bariatric surgery. So go slow. You know, if you're having problems, you can also know that vitamins could be one of the instigators. So kind of try different forms if you're struggling, or talk to your provider and see if they have some recommendations. There are different things to help with that. I would say one of the biggest things is fiber supplements, more fluids, activity can be big things. So that's all on that slide, Heather.
So why do we take our supplements? Not just because our surgeon tells us. I'm telling you, if that's your reason, you won't keep taking them. That's not a good enough reason. So you kind of have to figure out what your why is. And you can see this one's the one sticking out of the pie, because for most patients, enhancing their weight loss, well, of course, we want to make this process, work better. Why wouldn't we want to do that? Well, then let's optimize our nutrition in order to do that. I find it interesting that patients will take a hair, skin, and nail formula, but skip their multivitamin. But if we just, for a lot of times, took our multivitamin and got our protein in, we actually don't need the hair, skin, and nail formula. So you definitely will experience improvements in your hair, skin, and nail health if you optimize your nutrition. Less joint and muscle pain. Obviously, it'll help try to keep your labs within normal limits, give you better energy levels, and then also optimize your metabolism, which then plays a role in enhancing that weight loss. So a quick intro to ProCare. I'm going to keep this super, super fast. What makes ProCare different? We are really big on innovation. This is a big part of why I joined ProCare and part of what I will be continuing to help drive. They've done a great job up to this point, and you're not going to see it stop. We want it to keep going. But ProCare was the first in the US to have a 1-a-day for bariatric patients. This was a big deal. I mean, before this, patients were 2, 3, 4 times a day. Also the first to have a bariatric prenatal multivitamin, and the first to offer a multi for SADI patients. Also the first to combine a probiotic with a multi. So lots of innovation there. Affordability, not only are we, more affordable than a lot of our top competitors, we now have a price match guarantee and that subscription service and free shipping. So check those out. Quality, all the things I told you to ask for, we do. So I'm not going to harbor on those. And then, as I mentioned a little bit before, we're very patient focused. The fact that ProCare employs a dietitian and a nurse, I think it's huge. I don't know of another company that does that, but I could be wrong. But we're always thinking about how our business decisions impact the patient. And our whole goal is to create products that will enhance your life, prevent nutritional deficiencies, and hopefully make it easier for you to take your supplements. Those are references, boring. So.
And I'm gonna just say that we do have the handouts accessible on our website. I will show them how to access those. And Heather, I'm gonna share my screen real quick.
Yeah, I think you should be good to go.
Okay. Here we go. Let me just do entire screen for right now. And I'm gonna jump on over to the ProCare site. It's ProCareNow.com is the website. When you get there, you're going to see all kinds of tabs at the top. If you migrate over where it says Berry Connected, there's a tab under that. It says Support Group Handouts. And when you click on that, you're going to see so many handouts, guys. About halfway down is where you'll find the little pop up there, the presentation for today, and the title of it is all about vitamins. We've just updated our presentation, kept the other slides on there, so you can take a look at those too, but presentation 2 is where we're at. And I'm just going to kind of pull those up, talk about them briefly. We have taken the first one here with talking about the digestive system and nutrient deficiencies. We kind of have some summaries on that slide. A lot of what we talked about, I won't say everything, but a lot of what we talked about are on these slides that I'm going to be showing you. I'm not going to go into any depth. We actually have divided out by surgery type, the different types of deficiencies and what you might see, including the frightful 5 that we talked about, where the vitamins are absorbed in the intestinal tract, including the small intestines, including the duodenum, the jejunum, and the ileum, and then the large intestines. So if you're interested in kind of like, if you're want to be a nutrient geek like us, you can kind of dive in and look at those. And then we have a whole slew of other handouts divided out by surgery type. Okay. We have the band, we have the sleeve, we have the gastric bypass, we have the duodenal switch. We also have a handout that includes all of them on one handout. So if you're preparing for surgery and you don't know what surgery you're having yet and you want to just take a look, I'm going to go ahead and pull up the sleeve gastrectomy because I know we always have a lot of sleeves on these calls. But the first page will show tips and recommendations for all patients. And then each slide will kind of go through the different recommendations and the amounts. So again, you didn't need to screenshot those particular ones because all of that information is here.
Boring
we
chart.
Also, yes, we got it in a nice little chart. And then we also have here on the next page, a sample of supplementation, what that might look like. So for breakfast, You might want to take your multivitamin, midday, a calcium chew, afternoon snack to help get in some more calcium, and then your PM, a calcium citrate. So depending on what you're looking at, might depend on what like your surgery type. Each of these are divided out though. So you can, if you had the bypass, same, you're going to see the same sheets, and you're also going to see for that.
And
So
I've dropped all of those links into the chat by surgery type. So they've got those there.
oh, awesome, Heather. And if you're listening to the replay, guys, you're going to find these in the description as well. So whether you're on the podcast or you're on YouTube, I'm going to go back real quickly here to the website. I'm going to show you where to find some of these incredible products if you are interested in checking them out. So our bariatric multivitamins, there's a tab for that, including the one-a-days and the prenatal, the probiotic. We have chewable and capsule versions, capsule and chewable, and we have varying degrees of iron depending on what your needs are. So it goes from iron-free, 18, and then 45. And then I also want to mention under there, we have your calcium products, your proteins, and therapeutics. Right now, a lot of our therapeutics are kind of add-ons. Like if you want fish oil, or you want extra
Probiotic.
vitamin D. Yeah, or what did you say? Probiotics. Yes. B12. So there's a lot of those. A lot of those are on sale right now. Some huge, 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 incredible savings. I was amazed when I was looking through that. I'm like, holy cow. So those are something to kind of take a look at. I also want to just mention under the Berry Connected tab, guys, each month we have more and more of these type of live events. If you're ever interested in going back and listening to a replay, or you want to register for a live event that's coming up, all you have to do is click on to any of the events. This last week we had Jeannie Boyer, who's also a dietitian, talk about mind-body connection. So if you miss that and you want to go back and listen, you can click on it, register, and listen to the on-demand replay. Berry Nation is going to be talking to us next week. They're one of our partner programs, and they're going to be talking about 1 year post-op, now what? Additionally, the support group from tonight's, if you want to go back, listen to the replay. Guys, this was a great one to listen to a replay to try to absorb more information. So know that that'll be on demand until the end of the month. I also want to say all the replays also go onto our podcast, which is called Berry Connected, and you can listen to that on your favorite podcast station. If you want to click on any of these icons, it take you there. And then on our YouTube channel, we actually have the YouTube channel, instead of it being Berry Connected, is under ProCare Health Vitamins and Supplements. And we have close to 300 videos on there now of all kinds of replays, all kinds of fun things. There's playlist. If you click on that, we have recipes, we have frequently asked questions, all kinds of fun things. So any kind of topic you can imagine. When you get there, press the subscribe button. There should be a subscribe button up here, and you'll get reminders of when new things are added. Also want to just mention, we just, on this Berry Connected page, we also have down here below, add us on Facebook or join our Facebook group. You can click either of those. On Facebook, our group is called Berry Connected. And then the page looks like this. And then we have a Facebook, this is our group, and our page is called Berry Connect. Berry Connect. So we had to change one of them in order to be Facebook compliant. So it's Berry Connect and Berry Connected.
And
So
I've
I'm going
dropped all those links in the chat, so they should have all of them.
thank you, Heather. And I'm going to stop sharing. And I know there's more questions. Guys, I know we're kind of over time a little bit, but we can definitely kind of look. I think we can take a couple more questions. If anybody does need to jump off, please feel free. Again, this is on replay, so you can always come back.
I think we've actually, unless some new questions come in, I'm scrolling through them.
There is one. Can you send the link to our email? So you should have, when you registered for this event, you should have gotten an email reminder from Zoom that actually will have the link in it, and you can click on that to listen to the replay. If that's the question, about if that was in regards to the replay.
I just want to say, I'm so glad that you guys are finding this helpful. I know I'm a nerd, a nutrition nerd, and And I get excited about all this stuff, but I love hearing that you guys find it helpful and educational. So thank you for sharing that. I'm glad that it's helping.
And there's a question, how do we let you know who to send the attendance to? So if you know that your program gets attendance to these, you can check with them. If they do, I'll be sending that out at the end of next week. When you registered, you would have put the name of your program in your registration. And so I actually know how to sort those, and I sort those and send those out to facilities. So I'd be happy to do that. If you're not sure if your facility gets that, my last name is Hain, Hoehn. My first initial B at procarenow.com is my email. So hainb@procarenow.com. I'm typing it in the chat. And I usually do that, if you join late, I usually do that about a week post the event in order to capture replays. So I think we got it all. Thank you, everybody. Like Heather said, I feel like it's a blessing to be here with you guys. Like for me, because it keeps me on point. I had weight loss surgery back in 2013, and it helps me keep in check with everything. So thank you.
Thank you for
Yeah.
having me, Brenda. I really enjoyed
Yeah. Thank you too. Everybody have a great evening and enjoy your weekend.
it. Yeah.
Thank you. Bye-bye.
Bye, guys.